Dr. Karim Kalache, our second speaker for our first topic for today. So now is the time for our question and answer portion, of course, to both our speakers for today's symposium.
So Nassim, I want to ask you that cell-free fetal DNA is used on which cell? Fetal RBCs or fetal white blood cells or fibroblasts? Which cell?
These are free DNA, you know. This is the first thing I told you. That was the fetal cell. Okay, those are nucleated RBCs. And they were so little in the maternal circulation that they had to stop the research because it was not effective. So these are free cell-free. Okay, so what is that the cell? The cell-free fetal DNA in the maternal
Maxillary.
My question to Professor Karim Kalache. Thank you very much for your nice presentation. Regarding the fetal bleeding after anemic.
Yes, I think you're right. I think, you know, when you do an amniocentesis, we know what can happen. I mean, it's very, very rare, but the one I'm talking about is because I think Down syndromes can sometimes have a problem with their, hematologic problem. So with their, and also severe IUGR. In the past, we were doing in IUGR babies to exclude genetic disease.
You consider it very high risk for abnormality, and you will refer directly to invasive procedure. You will not give it a chance for non-invasive procedure.
Okay. As of the indication is that the woman was older. Okay, she had what you call ultrasound, fetal ultrasound. Okay, trans-abdominal most of the time, might be transabdominal also. The nuchal fold was more than 3.5. Okay, so in those cases, you don't go for, or maybe you say 5-6 millimeter. In these cases, you know, if you go for NIPT, first is, as I said, the NIPT detection rate is so high, the cutoff line. But then, if you are seeing a younger woman, and I'm sure you know the place, of course, you know, it is your own judgment. There are no, I mean, there are some gray areas, right? Not everything is black and white. In those cases, your clinical judgment
Was seen, and then an NIPT test was done and was okay because you look for the trisomy 21 and all these things, and the baby had later on a genetic disease, and the patient was very disappointed. So I will really, you know, I mean, do the NIPTS, it's good, it's avoid the procedure, but always, I don't know how to do it. Maybe to be a bit on the careful side with saying if it is normal, it will be okay.
Question?
Sure.
Regarding one of your slides, you mentioned that the specificity and sensitivity of the test NIPT is almost 99 to 100%. And you mentioned that there is false detection rate, about 2 to 5% in the common aneuploidy. And if other chromosomal aneuploidy, it is 25%. Actually, 2 days ago, I have one patient who had Turner syndrome. And it's mentioned that the accuracy is 99.9%. So what should we counsel this patient? If you have false detection rate of 25%, she has good chance that the diagnosis is wrong. So what should we counsel this patient?
And they have family with hemoglobinopathies like sickle cell and major thalassemia, and they do not have good family. All children are affected, and they are coming with a mother pregnant now and asking you, do you have any test, non-invasive test to tell us if this baby is affected or not?
Yeah, that is a
If they want
it is
to have
possible.
a clear diagnosis.
It is possible. There is clear
Is
diagnosis.
affected or not
Yeah.
by non-invasive technique, of course. They are looking for non-invasive technique.
Yeah. NIPT is a future, technology.
Future, not now.
No, they are doing it, but clinical implication comes in future. See, like cancer cells, I said, right? In a cell-free DNA, detection of cancer cells in a baby. They're doing it. I have heard the lecture in Singapore. They're doing it, but these are at research level. Okay, how far it has come into clinical implication, we have to just wait and see.
Maybe
Thank you.
because you are a great teacher and you like teaching and transferring knowledge and ultrasound. So how do you think? How do you teach? Are you in your center? Do many do the amniocentesis or because I think it will still be around for a while, amniocentesis and CVS.
This is a very good question. I must admit I miss the HMC and the teaching environment and many people around you. So teaching amniocentesis is quite easy because, as you said, the procedure is quite common procedure, it's quite simple procedure, and all the invasive testing are the same. Once you get the principle, it's quite easy. Now, ask a question directly at the FMC, the private center, so only me who's doing it. And that's simply because the number is not as big as before. When I started 2012 at the private center, I was doing about at least 2 or 3 per week. Now I do 2 or 3 per month, even sometimes less than that. So it is a good news. I'm not doing laparoscopy, who are very good at this. Some people doing amniocentesis and CVS like myself. Some people doing gynae-oncology. There is a place for everybody, but you cannot do everything because there is so much knowledge outside there. And if you want to do the best for your patient, you cannot do everything.
Yeah, I think I agree. And just because you said at Sidra, at Hamad they do them all the consultants. At Sidra we have MFM. By respect for the procedure, they just didn't apply for the privilege. They say.
Just I want to ask you during fetal blood sampling, how I can differentiate it with the needles anchor between vein and artery? How I can do it?
Yeah,
during the procedure itself.
Yeah. No, the artery is much.
Typically, in the second trimester, we offer patients amniocentesis. Now, if you had a patient that came to you and the placenta was anterior and you wanted to obtain a sample for karyotyping, and you had difficulty accessing the amniotic fluid just because of position, etc., would you go through the placenta or would you just do a CVS? Because it's often a challenge.
No, I will. I mean, all his CVS is transcervical, and then the transabdominal technique came. Somebody who has done many years transcervical should not be forced to do them transabdominally, and he will not do. And I have no idea how to do a transcervical one. I've never done one. Yeah.
Charles Rodak doing it, but he was the only one doing it.
It's-
At that time, it was only cervical.
Sorry. The first technique was transcervical because it was even probably done without ultrasound.
The answer. So with this, ladies and gentlemen, thank you very much again to our speakers. Dr. Nasim Rashid and Dr. Karim Kalabshi. So before
Well, thank you for this kind of invitation from Mr. Badra. Now, if you go back historically and look at it, first trimester scans traditionally were done for dating and for viability. And then CVS came along in the 80s and it was done for that reason. Then first trimester NT screening came along. And then more recently we have NIPT screening. And the question people ask is, well, if NIPT can give me a lot of information that you were doing the first trimester screening for, what's the role of doing the first trimester scan? I argue that it is probably even more important, and this is what we're going to try and talk about. So, as far back as 2013, there's already been long-established guidelines by ISWOG for first trimester scanning and the standards that we should expect, or certainly be able to fulfill if we're doing first trimester scanning. Before 11 weeks, we determine viability, we obviously count the number of babies, determining periodicity and mionicity, and also then plan for when we do the NT screening. Before 11 weeks, I suppose the detection rates for anomalies is kind of limited, and we'll touch on that in a bit. But when we then move to second trimester, or sort of late first trimester scanning, in the NT period, so to speak, then that's the period that offers us the greatest ability to detect anomalies. And we're talking about the 11 to 14 week scan. In addition to confirming viability, it also allows us to date the pregnancy accurately. We can detect gross abnormalities and measure NT. And there's certainly a grade A recommendation from ISWAG that every pregnant woman should be offered an ultrasound scan between 10 and 13 plus 6, because that allows us to accurately date the pregnancy and plan her pregnancy care appropriately. And I think, just having been here for a year, that's certainly a challenge, because that doesn't always happen. If you look at the ISWAG guidelines, this is the sort of stuff that we should be able to detect. There are some that are ideal, there are some that we should definitely be able to 100% detect. So we can slide down in terms of systematic approach, the head, the number, the cranial vault, the midline, the choroid plexus, all the way down to the extremities, the abdominal wall, etc., etc. This is a more recent paper from the Netherlands, which looked at first trimester screening in the world of cell-free fetal DNA. And essentially what they did was, we'll talk about this a bit more later, but they also have a very systematic approach to how you assess the baby in the first trimester. And all they did was offer sonographers a bit of extra training, and they were able to show that actually first trimester screening is very, very good in terms of detecting fetal abnormalities. And we'll come to that later. So how do we go about the first trimester scan? Obviously, as I said, we need to be systematic. What anomalies can be detected, we'll touch on those. You need to be able to get the best out of your machine. I mean, a lot of machines now have automated, so you have them optimized for various trimesters, but you may be able to improve the quality of what you get by tweaking the machines. There's certainly an improved visibility with transvaginal scan, and 3D or 4D may add some benefit as well. It's always important to remember that when you look at your classic second trimester scan and some of the features that we describe as traditional, they may not be manifest when we do a first trimester scan, and it's important to remember that. So for example, if you have renal agenesis in the first trimester, you will find that in all probability the lac of volume is normal. The classic lemon and banana shaped cerebellum, which you get for open spine epiphylla, will not necessarily be there in the first trimester. And it's unlikely that you're going to see big 16 lesions in the lungs and the kidneys. And polyhydramnios and oligohydramnios tend to be unlikely at that phase as well. So these are sort of things that you need to remember. The other thing, of course, is the physiological herniation that you get in the first trimester. So it's important to be careful when you're going to diagnose cases of exemplars, particularly in patients less than 10 weeks. So NT scanning is pretty much the norm. Always remember that this is a choice. It's not a necessity, and it's always important that if we're offering NT, the patient is appropriately counseled and understands the reason why we're doing the test. Okay? Because obviously if you find someone that you just do an NT for and you haven't counseled them appropriately, you find yourself in a bit of a sticky situation. So the patient needs to understand why you're offering them the NT scanning. Now, when we talk about NT scanning, traditionally it was all about aneuploidy screening, particularly Down syndrome. Down syndrome has always been the #1 thing in terms of screening, particularly because it's the most common aneuploidy, but it's by no means the most significant, largely, as you all know. Now, NIPT has come along, and we can make the argument, certainly with the data that you've seen, that it's a better test for detecting Down syndrome. So NT is not just now about first trimester Down's detection. If you have a raised NT, traditionally we then assess and discuss the risk and offer further testing. And the question now is, what sort of test do you offer? You may be able to, it's also important to understand that a raised NT is an indirect marker of other fetal anomalies, and the classic ones we talk about are things like cardiac problems. It may be a marker for thoracic masses, congenital diaphragmatic hernia, skeletal abnormalities, or also syndromes as well. So the argument is that with raised NIPT has a limited role, and we really should then be moving on to more extensive assessment of the fetus rather than just offering NIPT, because what NIPT offers is restricted. So these are your sort of traditional classic NT view. Now in this view, it gives you a lot more information about, you get a lot of information about the baby. So you measure the NT, you can see the nasal bone, you can also assess the palate there, the profile, the intracranial translucency. In this one, you put it on and you know straight away there's a problem with the baby. So there's a first impression that you get when you put the probe on the patient. Now this is a patient from a few years ago that we had. She came in for a dating scan. We put the probe on, and clearly straight away you could see that this baby was hydropic, the NT was raised. She had a karyotype. It was Turner syndrome, which is pretty classic sometimes when you see this picture. She wanted to continue with the pregnancy, and so we offered more detailed scanning later, particularly a fetal echocardiogram because of the association with Turner syndrome. As I said before, if you get the profile view on sort of the NT picture, you can also sort of see very clearly in this view where you get a receding chin, which is what you describe as a Micronesia. The diagnosis of Micronesia is subjective, but there are objective ways of measuring it by using the inferior facial angle and the jaw index. Can be associated with syndromes. The particular one that we think about is PRO1 sequence. And there's an interesting paper from Palladini in the White Journal in 2010, which suggested that when you be very careful about making a diagnosis of isolated Micronesia, because oftentimes these babies have other problems, and up to 80% of them would subsequently have some syndromic component. So be very careful when you describe them as isolated. This is a paper from Rabi Shawi, again in the White Journal, which gives you some idea of the benefit again of the facial profile, and it's about being able to make a diagnosis potentially of a cleft palate. And this is, we're looking at what we call the maxillary gap. So this is a normal, what you should find normally. And you can see in these other pictures, you see quite clearly a nice gap there. And this, when you observe the maxillary gap, it was seen in 96% of patients with cleft lip and palate. Most of those patients had additional defects as well. It was only seen in about 2/3 of those that had isolated cleft lip or palate, but it was also present in 7% of normal fetuses. So if you see that, it is suggestive of a cleft lip or palate, and is indicative of the need to look a bit more closely at the baby as well. So this is kind of the classic traditional diagnosis that we should all make 100% of the time. Okay, what is that? So it's your cranial spectrum. Okay, so that baby, the absence of the cranial vault is just the membrane covering the brain, and this is something that we should make a diagnosis 100% of the time. So what is a crania? It's the most common neural tube defect. The incidence is about 1 in 1,000. So with the 26,000 deliveries that we have across the country, we should expect to see close to 30 of these cases every year. It's lethal, essentially. We should make the diagnosis in the first trimester. And it's the patient's choice as to how they want to proceed with the pregnancy. Traditionally in Europe, most patients will stop the pregnancy, but it's not unheard of for them to want to continue. Very important, obviously, in terms of counseling for the next pregnancy, that there's a high risk. It's related to folic acid deficiency, and so one of the things that you can do and you must do is offer them high-dose folic preconception with regards to the next pregnancy. And then you slide down up towards the face, and this is a 14 weeks, so just slightly off where we are, and you can see there that you can see the lip and you can see quite a big cleft. Okay, so it is possible to diagnose in the late first trimester. So this is your traditional sort of section for measuring your BPD and head circumference. It's the transthalamic plane. You should see the cranial vault all the way around. You should see your cerebrum septum. You should see your falx all the way across, and your choroid plexuses. So that view allows you to be able to make diagnosis like this. So you can see clearly there's an absence of a falx here. This baby also had raised NC and a cystic hygroma with a holoprosencephaly. So in this situation, you would offer karyotyping to be able to detect what the situation was in terms of aneuploidy. Holoprosencephaly basically results from failure of the forebrain to differentiate into the two hemispheres. Classically, midline features also affect the face. So if you have a problem with the midbrain, you also get problems in the midface, and also all the way down the baby in the center. Associated with microcephaly, important to exclude associated anomalies. Typically, the association is with trisomy 13, and you should offer extended testing by way of microarray. So if we go on again to some other sections of the head, you can see quite clearly there's a gap at the back of the head with brain or meninges herniating out. And this is your spectrum of cephalocele. We should diagnose them again, as I said, typically in the first trimester.